So today we have two extraordinary students, Thomas Lee and Mikine Hirano. Okay, so guys, please say something one-liner about yourself. Outside of medicine would be fine. Thomas, please.
Oh, okay. Hello, my name is Thomas. I'm a medical student at Johns Hopkins University School of Medicine in Baltimore, Maryland. I am a third year, currently taking a year off to pursue my MPH at the School of Public Health here. Outside of medicine, I feel like during quarantine, I've been cooking a lot. And so maybe about 2 weeks ago, I made croissants. And I was reminded why we buy croissants instead of making them, because it was very difficult.
Mm-hmm. Right.
Right, yeah, so my turn. I'm Mikine Hirano from Keio University School of Medicine, and I'm a sophomore. And outside of medicine, I play piano, classical piano, and I like music, so I create music. And so, yeah, I'm trying to be kind of like a producer as well. And, I play football. I'm in the soccer, not American football. And yeah, that's pretty much it. Thank you.
Please make the theme music for this YouTube channel.
Great.
So today we have a case from Johns Hopkins University. And the case is 65-year-old man with shortness of breath. And chief complaint is cough.
Should we come up with read the HPI here?
Yep.
So is this all the info we get right now?
Yep. Mm-hmm. We have 7 aliquot today. 701, and this is first aliquot. And the first aliquot is usually about chief complaint, and maybe second would be review of systems, and third would be social and past medical history of things like that. And final aliquot is usually diagnostic.
I guess the chief complaint would be cough. It's a dry cough that has worsened over the last 6 months and is associated with shortness of breath at rest and with exercise. If you don't mind, Miki, if I just kind of talk this through a little bit first. Mm-hmm. So in terms of tempo, it seems that this is a progressive sort of etiology. It's not acute because it's worsened over the past 6 months or so. It's dry. So could be infectious etiology, but dry kind of opens up the possibilities a little bit. Doesn't look like there's any sputum, anything like that. Associated with shortness of breath at rest and with exercise. So it's not exertion induced. So that kind of helps us when we're thinking about things like congestive heart failure or anything that would be exacerbated with exercise, like congestive heart failure or asthma or something like that. What do you think, Miki?
Well, at first I thought it has something to do with the respiratory organs, because it says, like shortness of breath and something like that. And yeah, for the rest, I do agree with you. That's pretty much I can say right now.
I'm curious, at your school, how do you come up? What is the process for coming up with differentials or like a differential diagnosis? Is there a framework that you use?
Like for example, what Dr. Yoshino told me before is that when the chief complaint has something to do with the pain, we use like OPQRST. Am I right? I'm not
Yeah.
This is a framework for asking the patient about chief complaint.
Right,
yeah. And maybe Vindicate would be the framework for making the list of complete differential.
So definitely, I think there's different frameworks that exist out there, and Vindicates is one that I've used as well. And another one that I have heard of is organ system. So you just literally go organ by organ, or anatomical as well, where you go like from the outside in all the way through to the back of the body, and you just consider every layer and what possibly you might encounter. So in this case, though, I think Vindicates are probably work pretty well. V is like vascular conditions. Of course, we can always put down vasculitides. So I in vindicates is infection or inflammation. Do you have ideas of what possible infections this may be?
Well, to be honest, I have no clue at the moment. Like, if there is any sign of sputum, I think we can kind of like narrow it down to like the sort of infections. But as it says, dry cough, it's kind of hard to get it down there.
Yeah. I mean, when I hear dry cough, instead of like something very productive, and also because it's so long, something that comes to mind is like atypical infections, especially in the older population. For example, like Legionella or something like that, because those usually also present. They're called atypical pneumonias for a reason. It's kind of a strange sort of presentation.
As for Legionnaire, you said, isn't it kind of necessary for Legionnaire patients to have high temperature, like over 38 degrees or something like that?
If I remember correctly, I could be wrong. There are like different presentations of Legionella, and so I think that's particularly called the Pontiac fever, presents with high fever. But I think also Legionella can present just as like a cough in itself, though we don't know if he has a fever or not yet because we don't have a physical
But like,
exam,
if he has fever, it should be spot on the. I think we can narrow like some information down when we go to the next step, and
neoplasm could be lung cancer, unfortunately, or metastases to the lung, which would be a dry cough, and also can explain the shortness of breath at rest and with exercise. D is for drugs/toxins. So I was thinking like there are definitely drugs that can cause dry cough. Like ACE inhibitors is very classic example of dry cough causing, but so that could be it. Might not, well, you could argue like in a very long string of logic, like if they're taking an ACE inhibitor, maybe they're fluid overloaded or they have hypertension as some sort of chronic like fluid overload state, chronic kidney disease, and so they need ACE inhibitors. So if they're taking ACE inhibitors, then it causes the cough. But that's kind of like a long train of thought, but I guess it's not out of the question. I in vindicates is iatrogenic idiopathic. C is congenital inherited, which is much less likely in a 65-year-old perhaps. A is autoimmune, allergic, or anatomic defects. Yeah, this could be like some sort of eosinophilic. So it's pretty rare for, especially it's a male, right? So I guess it's kind of rare for at an old age and a male, but it's not out of the ordinary for that to happen. Of course, in medicine, those things always happen.
I'm not quite sure with the duration. I mean, the 6 months, right? If allergic reaction continues for like 6 months, it must have been a big problem, like more than this. So, for example, like the environment or the like living place that he's in is something to do with the allergic reaction. Yeah, that would be a case as well.
But, yeah, I think that's a great thought. Yeah, for sure. Yeah, I think adult onset allergies isn't out of the question, and it's not necessarily uncommon, especially in the case you mentioned, if they like they move to a nursing home or something, and there's like a lot of mold and mildew and dust stuff there. That can definitely. That's not unusual. But okay, and so then the next thing is T is trauma, which doesn't seem like the case just because it's so long. And then finally, E is endocrine, metabolic, and exposures. So we're talking about the exposures, like the allergic exposures. Okay. Anything to add, Sensei?
Not really. I think we're off to the next.
Yeah, but it was great discussion, I think. And you said atypical pneumonia, and maybe chlamydophila and
TB.
Yeah, and TB. Yeah, TB is possibly productive and sometimes bloody, but yeah.
Oh, that's right. That's right. Yeah.
Yeah, but TB can be presented as with a dry cough. Yeah, and it would be chronic. Yeah, it's good. And for neoplasm, lung cancer is definitely the first line choice. And we think drug. And one we said about asthma or any other kind of exposures or allergic reactions. And one more thing we have to think about would be GERD, gastroesophageal reflux disease for such
dry cough. Yeah.
Patients dry cough. Yeah.
Yeah,
And sometimes postnasal drip or chronic rhinitis would be differential for us right now.
Yeah.
Okay, so let's go to the next article. Okay. Oh, very small information. Yeah, smoking is definitely one diagnosis.
Yeah, that's true. Good point.
And non-smoker. He said non-smoker. But we have to check how much
that's from whether we actually trust him saying he doesn't smoke.
Yeah, sometimes 1 week non-smoker said, okay, I am non-smoker for 1 week.
When, let's say in like writing notes, for example, it's common in Japan to use like pack years, right? Like the concept of pack. Oh, okay. Just making sure. In a sense, I feel like, so maybe we're unsure about smoking status. And that isn't, I feel like because we were thinking about like lung cancer, it doesn't necessarily rule out lung cancer, but it does make it lower in that case, right? Yeah.
Right. Especially for squamous cell carcinoma, it would be listed as lower. Yeah, still we have adenocarcinoma.
Yeah.
We have another differential, COPD, and it is also strongly related to the smoking.
Perhaps like fluid overloaded state, or like congestive heart failure, any sort of fluid overloaded state might be a little bit higher in this case. I think, but I totally forgot things like GERD and allergic rhinitis as causes of chronic cough. Also, just in terms of common things, could just be very common, very possible as well, especially in non-smokers too.
Yeah. Okay. So next article would be fine for us. Okay.
Yes.
SaO2 91% on RA. Other vital signs are remarkable. And CV normal rate, regular rhythm, no murmurs, rubs, gallops, no JVD. Lung mild wheezes, hard at bases and faint crackles, and extremities, no peripheral edema. I'm slightly concerned about the SaO2 because isn't it kind of low, 91? I mean, I've learned about SpO2, and if SpO2 is 91, it's quite a. Well, thinking about TB, is the SaO2 kind of decrease or?
Yeah, I would expect SaO2 to be this low in I would say in addition to TB, like a lot of infectious etiologies, and in a sense, I also feel like what would cause his referral to the hospital would be if they saw his SaO2 is this low after presenting to a primary care physician and being like, I'm kind of tired, and you measure SaO2 and you see like dipping into the 90s, low 90s, you're like, you need to get worked up in a hospital to get like chest x-ray and things like that. Yeah, what's interesting is, so his other vital signs are unremarkable, so it doesn't look like he's tachycardic or anything like that. Like any sort of chronic inflammatory state, perhaps, I guess that isn't, it at least tells you it's not necessarily acute process is what we thought of. Normal RRR, no murmurs, rubs, gallops, and no JVD. So that essentially almost, and especially with no peripheral edema, that essentially rules out fluid overload, which would be, at least in the US, would be immediately what you think about for any patient like this. You're like, definitely fluid, like definitely decompensated heart failure or something. But that helps rule that out. I see the lungs, the mild wheezing, hurt at bases, and faint crackles. I see that, and I'm thinking like, okay, faint crackles could be a lot of things. So could be indicative of some fluid buildup in lower lungs, especially because it's in the bases. So So in terms of gravity, we would expect fluid to collect at the bottom. And so that kind of helps cue us in that. We're not really sure what the fluid is. Could be, and like really any sort of liquid, like could be liquid, could be pus, could be lymphatic fluid, not entirely sure. Mild wheezes kind of convey, when you use the word wheeze, it does convey some sort of like allergic asthma sort of vibe to it. From what I learned, you can really hear wheezes in a lot of things, but it does convey some sort of like autoimmune process, potentially because of that. If we go back to what differential was, in terms of like the common things, like GERD might not be necessarily on as high up anymore in a differential because we can examine and hear some lung pathology, and also the vital signs point to that. Allergic rhinitis, like while that might be the case, I wouldn't really necessarily explain the SaO2 decrease unless it was like a decompensation of asthma. So it does suggest some sort of chronic not destructive is not the right word, but some chronic inflammatory process. Something I think like lung cancer is still on. Cancer is always on the differential until you get imaging. So so cancer is still up there. Something like EGPA. Yes, formerly Church-Strauss syndrome, eosinophilic granulomatosis with polyangiitis could be because it can present with asthma-like symptoms, especially if it's focused around the lung. And the infections that we've mentioned, like chlamydia, Legionella, TB, those are still not necessarily off the table either.
We have to think about the vindicate still, but for the organ, we can focus on the lung or possibly cardiac. We can still have several systems, system possibilities about infection, neoplasm, allergic. But
what would be a cardiac potential cause of his symptoms? Especially with his like benign cardiac exam? I see. Oh, I was thinking perhaps also the like maybe would this work? Like high output heart rate failure, where you wouldn't necessarily see fluid overload, but it would also be heart failure in that case as well.
Very small.
Oh, wouldn't it be like acute?
I think for sure, but at least in my experience, there are patients who are, it's kind of like they show up to the clinic and they're like, I've been having a hard time breathing, but you know, I'm here for like a vaccine. And then it's like, oh wait, let's measure your SaO2. Oh my God, like that's how I'm imagining that sort of scenario could play out. Perhaps.
Okay.
So we have another 4 aliquot. So
right, let's move on.
So what they got here is a pulmonary function test, which is basically essentially a tube that you blow into, and you ask the patient to like blow. Yeah.
Right.
Yeah. So
and you get to have like this kind of like not square.
Yeah. There's these sort of.
And then if you're
curves.
then if you're asthma, the line can like go.
Yeah, it kind of curves in a little bit. Right. So
okay.
So what the FEV1 is, it's expiratory volume in 1 second, and so it's a function essentially of how good your lungs can work, how much air you're able to expand out. And in this case, it's of interest because if you have pathology that causes your airways to be obstructed, that is that when there's a large amount of air blowing through your lungs don't have the necessary support to hold that, and so they want to collapse. That would be reflected in the FEV1, and you always compare it against the FVC, or the functional vital capacity, or let's say your total lung capacity. And so here, when we see the FVC is normal, what that does is that helps us in seeing that, okay, it doesn't look like the lungs are abnormally have more lung capacity or less. And so there is lung pathology that kind of closes down your lung space, like granulomatous processes, like interstitial lung disease, where there's just kind of scar tissue and it kind of reduces the free space in your lungs. So that would cause reduced FVC. And the classic thing that causes increased FVC is emphysema, or just destruction of the lung parenchyma that causes extra space. And so the fact that FVC is normal means that it's neither one of those. So that helps us out a little bit. FEV1 over FVC kind of tells us that it's an obstructive process. So there are a couple things it could be. Well, we kind of ruled out doesn't seem like it's emphysema. So something that's classically very obstructive is like an allergic process. Some sort of let's say spasm of the lungs, so that it causes the lung walls to collapse very easily. But what's interesting is that we see in bronchodilator therapy no improvement in FEV1. So that's a very classic test for asthma. Is you administer a bronchodilator and you see if the FEV1 improves. And if it does, especially if you give an anti-muscarinic, but if you administer a classic, like let's say anti-asthma drug, and you see an improvement in their breathing and FEV1 during pulmonary function test, that's usually like a shoe-in diagnosis for asthma. But we don't see that. So,
doesn't mean that we can rule out the possibility of asthma because there's an improvement in FEV1.
There's some wiggle room here, because you can say like, okay, there's no improvement in FEV1, so maybe it's severe asthma, like it's real bad, or right. it could be like lung cancer. Still can be lung cancer. Could be EGPA or eosinophilic granulomatosis polyangiitis. I'm wondering, like, there's also like certain fun flavors of asthma, like aspirin-induced asthma, that's potentially, we don't know, but if he's taking aspirin every day, because of like chronic knee pain, like this, that wouldn't be improved, because pathway for aspirin-induced asthma is due to the mechanism asthma shunting towards like leukotriene pathways that kind of promote bronchospasm. So that could be non-amenable to bronchodilators. That's kind of my thought processes so far, but I feel like the picture is getting somewhat clearer right now.
FEV 1% is showing that obstructive ecology. The bronchodilator therapy did not treat the situation. That means kind of not functional, rather structural obstruction of bronchus could be there. So maybe tumor or chronic inflammation and making kind of scarrings of around, or fibrosis around the bronchus or things like that would be there.
So even something, well, but then the FEC is normal in that case, right? So it would have to be, because I just had like a thought of like sarcoidosis or something like that, but then I'm not entirely sure if sarcoid decreases the FEC or not. I don't think so, right?
I don't think so.
Perhaps the next aliquot would be imaging, which is what you would get. You would definitely get imaging before pulmonary function test. I think definitely. Like, there's no way you would do this first. Like, but okay.
Yeah, and if we can spot out like some sort of shadows, you know.
Right. Next aliquot.
Oh,
CT. Right? Okay.
Oh.
Quick question. So, in a case like this in Japan, would you just skip to CT, or you would also get chest X-ray too, right? Or
Yep.
Okay. Oh, this is all we get? Okay. We can't scroll up or down. This is all we
No.
For a CT, the feet are pointing towards you. Yeah.
All right.
The right side of the image or the left side of the body?
Left side, yeah, right.
What do you see?
Like, for example, like the upside of left, like left upside. That's not shadow, probably. I'm not sure.
Left side of the image, right? This one?
No. I mean, no, they're anatomically
the right
left.
side of the image, but anatomical left.
Yeah, anatomically left. I mean,
yeah. For me, I don't see any like obvious mass or anything. Though I do recognize some like signet rings. It's a dilated bronchus. It's typically seen in bronchiectasis. Or just like chronic inflammation of the bronchioles that cause chronically open bronchiole. So we see just like right in the middle of our screen.
This one
there.
Or this one.
This could be evidence of bronchiectasis, chronic inflammatory states in general, which is what I guess we were thinking about originally. This makes me less suspicious of cancer, actually, because this, for me, suggests some sort of chronic, more inflammatory state, because I feel like just from the image they showed us. Of course, we would look for cancer when we're searching on a CT scan, but the fact they gave us this kind of suggests they want us to think more about like the things that could cause bronchiectasis, like TB could, any sort of the autoimmune things that we were just talking about definitely could. Less suspicious of allergy, which I think Yoshino Sensei you were mentioning is lower on the differential just because of the non-reversal of FEV1 on bronchodilators. So yeah, I guess for me, I'm thinking of like some sort of autoimmune thing right now, which is always fun, or infection, like a chronic infection. It isn't, yeah, like I think TB would be, because I don't think like something like Legionella or chlamydia present in this way, but I'm not entirely sure about that.
Yeah, I also don't think so. And I'm thinking about a kind of COPD-like disease, because here is kind of grayish, and we have another space like here is more blackish space in the lung. So we have mixture of black and white in this lung CT. So it suggests obstructive lung disease and a breakdown of the alveoli.
I see.
Is that COPD?
COPD like
COPD
some sort of
or COPD.
Yeah. I mean, like
Yeah.
I learned in physiology that the presentation of COPD is kind of wettish cough. So
I've never heard that before, but I'm curious, like a mucus.
yeah, I mean, like associating like some sort of sputum or something like that. That's what.
Oh, people, and especially because the FVC or the lung volumes aren't different, that this being like pure COPD, especially in a non-smoker, is unlikely. But I think like the pathology in terms of the destruction is perhaps what is the more the thing that we can kind of start to key into here.
Next, Alika. Whoa, surgery.
Oh, okay. What did they do surgery? What did they take a specimen from? Like, what is, personally, I feel like when they do pathology or they do surgery, like they need to have like a particular target in mind to sample. Did they just take did they just poke a needle into this dude's lung and they're like, let's take a look. Let's see what's there.
This is very, very sudden surgery.
Yeah. So histopathology shows bronchiolar smooth muscle hypertrophy, diffuse fibrosis, and obliterative bronchiolar scarring.
Kind of chronic interstitial pneumonia, and it is called as BOOP, I think.
What? Oh.
Yeah.
This is something bronchiolitis obliterans. Yeah.
Yeah.
So to be honest,
there are so many kind of interstitial lung disease.
Yeah. So I read this and I'm like, oh no, this could be anything. There are iatrogenic like amiodarone that can cause some sort of scarring in this way, fibrosis. So it seems like any sort of fibrosing pathology is now on the table. Like what I said previously about sarcoid. Oh, this says COVID can cause this. Oh no.
Right.
Okay.
Yeah, actually,
we
COVID
should
can
always think about
make
COVID.
anything.
Yeah.
Right.
So COVID. COVID should have been number 1. 65-year-old. Oh,
yeah, exactly.
Man.
I mean, when is this case? When was this
made?
Is it in 2020 or something? If it's like prior to 2020 or like 2019, it can't be COVID. But if it's in there,
yeah, maybe that's the third aliquot, like 2020.
Yeah, right. Then COVID-19 then.
yeah, that would just pump it right up on top. So just to summarize. So we're thinking more it is some sort of inflammatory, what would cause this sort of histopathology is some sort of inflammatory insult on the lungs, which would cause this diffuse fibrosis, bronchiolar scarring, smooth muscle hypertrophy. We talked about a couple of possible situations where it could be iatrogenic, maybe drug-induced, or it could be like radiation. We don't know if this is like some sort of previous history, like perhaps maybe not neoplastic. I guess like we can't rule it out. Drugs do it. I mean, cancer is everywhere. Could be autoimmune. like sarcoid or sort of any sort of fibrosing etiology, I guess maybe you would consider COVID as an autoimmune process as well, or infectious, depending on the stage of recovery. We haven't necessarily ruled out infectious etiology because the tests haven't been done, and in sort of chronic inflammatory states, like you can have fibrosis, like in TB. Did I miss anything? Just wanted to kind of summarize where we're at.
Or COVID.
Great. Yeah. Okay. Last aliquot.
Yeah. And one my thought is about radiation will be this. And usually, if you have some kind of iatrogenic radiation exposure, it would make a very artificial line in the lungs. But he has almost complete change in his lungs. So I think it is kind of systemic.
Less likely. I see. Yeah. So I actually haven't seen images like that before. Like, is it like a definite line? Did you say?
Yeah, usually.
Oh, interesting.
Final aliquot.
Final aliquot.
Welder. What is a welder?
Someone who like joins iron together, like in construction, things like that.
Okay, so kind of
that came out of left field. Oh my god. So it could be
I can't really come up with anything.
Totally forgot. So could be welders, could be silicosis. I don't think it's berylliosis because I think like classically it's like people who work in the aeronautic industry and electrical manufacturing, if I remember correctly. I would think silicosis might be it, like or like any sort of pneumoconiosis, like which are lung diseases where that occur from a chronic response from your body because you're inhaling all these like super small particles in your lungs, and so when the macrophages in your lungs try to eat it, they don't know exactly what to do, and so it's just kind of stuck in the macrophage, and then an immune response happens around those macrophages, which kind of causes all these things. So the exact cause, I'm not entirely sure of welders that.
But berylliosis or silicosis.
Yeah.
Or any kind of metallic small particles.
Yeah.
Berylliosis. Yeah. Long time no see berylliosis.
I know. I'm like, oh my god, that's been so long. So just on looking up things, there's something called siderosis, where it's environmental disease of the lung due to, or called Welder's disease, where it's you have aerosolized, I guess, iron. I didn't know it could happen, but so it's just siderosis, siderosis.
And you said Welder's disease. Sounds great.
Yeah, it's called. Yes, definitely perfect. I had no idea that it could cause this, but
Welder's lung.
Oh, Welder's lung. Oh, there it is.
Oh, very biased.
Yeah, that's very helpful. I think we should put COVID. Let's see, is COVID on here?
Yeah,
but it looks like okay. Or we can put a more global word like interstitial pneumonia or BO, things like that.
Yes. I like it. Yeah. Interstitial pneumonia or interstitial pneumonitis.
Yeah.
BOO. I totally forgot about BOOP until you had mentioned it. It was like flashback.
But it is kind of insurance.
Yeah. It's like we did get it right. We just called it like a catch-all term. Parenchymal disease. Okay, I'm pretty confident with the Welder's lung.
I'm also.
All right.
Okay, so let's get submitted.
What? Oh, we covered it. Yes. Yeah. We did it. Boop.
Okay.
Yeah. Yeah, insurance is always very important.
What did other people say?
Okay.
Okay. Oh, lung cancer. Sure. Okay.
COPD or COLD is the top one. Lung cancer, interstitial lung disease, emphysema, heart failure.
We covered all this. We talked about this. Oh, alpha 1 antitrypsin deficiency. I guess.
We can't see it in Japan.
Wait, really? Alpha 1
Usually, no. It is very rare for us. Cystic fibrosis is also. It is very rare in Japan.
It's interesting because actually, I'm pretty sure there's an alpha 1 antitrypsin clinic at Hopkins. And actually, for 1 year in my, I guess, second half of first year and first half of second year, I worked at a cystic fibrosis clinic. So I saw only cystic fibrosis. So I had a very skewed view of how rare it actually was until I had learned about it. But until then, like every week I was talking with only cystic fibrosis patients. Yeah. But is it a genetics related cause? Is that why? Because I know cystic fibrosis is
gene.
Yeah. So anyways, we talked a lot about this long list, and I think we did a good job for this case.
Oh, I think we covered a lot of these actually. I think.
Yep.
Oh, MI? No, it couldn't be an MI.
Yeah, always MI.
That's true. I mean, yeah, I don't know.
Okay.
I just want to win, so we definitely won.
Okay, so we have 10 teaching points.
Secondary to inhalation injury from his employment, then we definitely got it. Like that's the number one thing we put out there. Okay, so he was given bronchodilators for symptom management because I guess you can't, because it's pretty much a terminal diagnosis. You can't really do anything except for symptomatic management, right? Okay, this next point I was talking about that differentiates the diagnosis from asthma, which would have a reversible change with bronchodilator therapy. Oh, the results from various treatments are inconsistent. You can give macrolide antibiotics, which I have no idea how they work. Would it be? Is it because it's anti-inflammatory? Is that why?
Kind of. You can see many cases who are taking macrolide for a long time. Yeah, it is not used as antibiotics, but anti-inflammatory.
Yeah. Okay.
Yeah, and first reference is came from Japan, maybe.
Yeah.
Oh.
And first author's name is Asthma. You know. oh. トーマスに通じてない。You know. Yeah, the sound is, his name is Asthma, Mr. Asthma. And this is a very famous name in Japan. And the sound is very similar to asthma, you know.
Oh, wait, but it's too recent, right? 2005?
Oh yeah.
Yeah. Okay. I was like, is it really? Oh no, probably not. But so
No.
does that mean any physician with the last name or of the name of asthma is like everyone's like, whoa, like very...
Not really.
No, but we talked a lot about asthma.
Yeah.
So this is very coincidence for us to read from asthma sensei. So this was my point, but it's okay.
わかりました。はい。I get it.
Good job, guys.
Great.
Great case. Oh, so many references. Okay. So this is kind of difficult case. But we've done well, I think.
So I guess, Miki, if you had to reiterate something that you learned from this, what do you think it would be for you?
Well, as usual, just looking at some well, firstly, chief complaint, and then we can like narrow like symptoms down to certain symptoms using the test, the result of the test, and yeah, also a lot of things. And as for this one, at first I wasn't really I didn't really know about the pulmonary diseases. So like throughout this session, I kind of googled it and every single thing up, and like I could find out a lot about it. Like for example, the symptoms, like for example, like for I don't know, COPDs, or like what was it,
bronchiectasis.
The symptoms. Yeah, like there were some things that like BF or no like it was abbreviated into
EGPA.
Yeah, EGPA, or like something like that. And then that was really good for me to get to know those diseases.
I see.
Yeah, a lot of things that I still don't know about like clinical reasoning. So
yeah. No, I definitely.
You nailed it. I think actually I haven't seen any BOP patient or welder's lung patient, but we could nail it because we are thinking pathophysiology, or we are thinking differential diagnosis systematically. I think you don't know all the disease, but you can think, or you can Google it with correct terming about patient. And my point is making correct understanding of the patient would be very important. And if you can put correct term to the Google search, you can reach to the correct diagnosis.
Yeah, I think like as an example, that even like at the end, like, because I know that there are a lot of different pneumoconioses, or the general umbrella pathophysiology is like when you inhale small particles, they can cause bad things to happen in your lungs, but there are different names for each one of them, and they have different risk factors. And although a better medical student would know them all, but I don't. So as long as I'm able to Google up like pneumoconiosis or whatever, or BOOP, as Yoshino Sensei mentions, then I'm able to like at least narrow that down. But I guess like even then, in the case of this app, that a lot of people didn't even go that far. They just generally called it like bronchiolar obstructive obliterans. Like they just kind of that's like it's like an umbrella term in a sense. So I can see even other physicians also thought the same as I totally agree. I think for someone that didn't really know a lot about pulmonary pathology, I think that you were able to definitely like keep up for sure, which is awesome. I think what I learned, one thing I learned was to keep in mind that although in the end this was something a little bit more exotic, I think like earlier on, at least in my diagnostic reasoning process, I want to have thought of those things, as you mentioned, Yoshino Sensei, about GERD and allergic rhinitis, which would definitely be like the most obvious common things that we would want to rule out first before thinking about cancer, especially if you're talking to a patient, you're like, you might have cancer or GERD, like one or the other, like so I think I didn't know the learning point about radiation though, so I think that was pretty cool, like being a straight line. But yeah, I felt like we did a great job. We covered a lot of it.
We did, guys. It was very fantastic case resolution.